Thank you for joining our quick talk on Marburg virus disease. My name is Gabby Frank. I am a professor of medicine for the University of Colorado School of Medicine, and I am the medical director for the biocontainment unit at Denver Health and Hospital Authority. We're going to be doing a quick review on Marburg virus epidemiology, clinical presentation, medical management, diagnosis, infection prevention, and we're going to give you some tips on how to reach us to ask some questions if you were to have any. So first of all, I just want to highlight that there is no conflicts of interest in this talk. All images are used with permission, licensed via Shutterstock, or appropriately credited. So Marburg virus is the causative agent of severe viral hemorrhagic fever. It has high fatality rate and has caused outbreaks in sub-Saharan Africa. Person-to-person transmission may occur in household or nosocomial settings where infection control modalities are suboptimal. Although Marburg virus was discovered over 50 years ago, licensed prophylactic or therapeutic countermeasures have yet to be developed. The clinical features and risk of spread of Marburg virus closely resembles those of Ebola. And we know that supportive care, infection control, and other response measures, such as the need for safe burials, are identical to Ebola virus disease. There is much less known about Marburg than Ebola because there has not been any recent large-scale outbreaks or for Marburg or equivalent to this in scale to the Ebola virus disease outbreak in West Africa between 2014 and 2016. So why did we decide to do Marburg virus right now as one of our quick updates? And this is because in July 7th of 2022, there was two patients under investigation in Ghana. And July 17th of 2022, the first outbreak of Marburg virus disease was declared in Ghana. There were a total of 3 cases with 2 fatalities, and all patients were members of the same family cluster. A total of 180 contacts were followed and screened during this period. And after 42 days with no new cases, on September 16th of 2022, the end of the Marburg virus outbreak was called in Ghana or declared. So Marburg virus is an enveloped, non-segmented, single-stranded, negative sense RNA virus in the filovirus family. There is a single species of Marburg that is called Marburg virus, which includes 2 viruses that have a 20% divergence. This is the Marburg and the Raven virus. Also, there's some other Marburg variants that have less genomic differences, and this include the Marburg Musuk, Angola, and the unnamed variant from the original outbreak in 1967. So the animal reservoir is presumed to be the Egyptian fruit bat, as we can see here in the picture. This presumption is based on epidemiologic linkage to outbreaks in caves or among miners in sub-Saharan Africa. RNA, antibodies, and viral isolation by culture have been demonstrated in a small minority of the bats. How about human transmissions? So the first human outbreak occurred in 1967 in Germany and Yugoslavia, and was related to the importation of African green monkeys, as we can see here in the picture, from Uganda. The outbreak resulted in 31 cases and 7 deaths, some of which spread by household or nosocomial contact. Since then, there has been nearly 600 cases in outbreaks originated in Uganda, Democratic Republic of Congo or DRC, and Angola. There have been fewer outbreaks of Marburg than Ebola. Marburg was presumed to be less deadly than Ebola until 2 large outbreaks occurred with high fatality rates. The first one was between 1998 and the year 2000 in the Democratic Republic of Congo and was associated with gold mining and resulted in 128 deaths with a case fatality rate of 83%. This outbreak was followed by the largest outbreak thus far that was in Angola in 2005 with 329 deaths and a case fatality rate of 88%. There was a recent outbreak of 3 cases in Uganda in 2018 and a 2-case outbreak that occurred in Guinea in 2021. The most recent one was the one in Ghana in 2022 that had a total of 3 cases. Overall, the case fatality rate from the outbreaks have ranged between 23 to 88%, likely related to the extent of supportive care available. And we need to highlight the household members and healthcare workers at a particular risk. So the initial transmission to humans likely occurs from bats or another intermediate host, such as non-human primates and bushmeat. But the route in specific body fluids involved, such as saliva from the bat, guano, or urine, is still unknown. Transmission to humans by direct contact with blood or body fluids of infected individuals or animals occurs, with the majority of the spread occurring through unprotected contact in the household or healthcare setting. There is a single reported case of live virus isolated from the aqueous humor of a human survivor more than 2 months after infection. So some degree of protected space persistence is thought to occur, but there is less data on Marburg survivors than there is for Ebola survivors. Although frank airborne transmission has not been demonstrated in humans outbreaks, droplet spread to mucous membranes presumably occurs. Also, there is some post-infection sexual transmission and recovery of the virus in the semen that has been demonstrated for Marburg virus disease. So we will move forward to discuss clinical presentation of Marburg virus disease, and we'll discuss the clinical spectrum, mortality risk factors, and differential diagnosis. This picture is from the CDC photo library, was taken in 1975, and shows the rash that appeared on the back of a Marburg patient who was treated in Johannesburg in South Africa. The image was captured during the 1975 CDC and Prevention Marburg investigation in Zimbabwe. This type of maculopapular rash can appear on Marburg disease patients around the 5th day after the onset of symptoms, and usually may be found on the patient's chest, back, and abdomen. This patient's skins blanch under pressure, which is common characteristic of a Marburg virus rash. So following an incubation period that ranges between 3 and 21 days, most commonly between 5 and 10 days, patients usually become abruptly ill with non-specific symptoms, such as fever, chills, headaches, sore throat, myalgia, vomiting, and diarrhea. Usually early cases can be missed because of the similarities with more common infections such as malaria, typhoid, and rickettsial diseases. The rash is a common feature in early Marburg virus disease and is described as non-pruritic, erythematous, and maculopapular. It may begin focally and then it becomes diffuse and confluent. And you can see in this image how it blanches under pressure. Conjunctival injection may also occur early. So during Marburg virus disease, large swings in body temperature have been noted, encompassing hyper and hypopyrexia. In the original outbreak, tachycardia corresponded to temperature elevation was only seen in fatal cases. So patients may develop multiple foci of mucosal hemorrhage, typically in the conjunctiva, along with early bruising or persistent bleeding from venipuncture sites. Renal function may be initially normal, although renal function is often impaired and dialysis may be required by the end of the first week of illness. Severe cases progress to hypotension, shock, and multi-organ failure. It is noteworthy that there is no evidence of a symptomatic Marburg virus infection. So common laboratory abnormalities usually include leukopenia and lymphopenia, hypokalemia, normal to elevated levels of amylase, thrombocytopenia, and elevated liver enzymes. As the illness progresses, elevations in prothrombin time and partial thromboplastin time, as well as clinical bleeding may occur. Patients may develop multiple foci, as we said before, of mucosal hemorrhage, and persistent bleeding, as we said before, from venipuncture sites. So the case fatality ratio has ranged from 23 to almost 90%. However, the two largest outbreaks had a case fatality rate of above 80%. Most fatal cases succumb during the second week of illness, with a mean of 9 days after the onset of illness. Those who survive this period are likely to recover. Risk factors for severe disease or death had been actually reported for Ebola, but not for Marburg. So basically, the risk factors have been extrapolated from Ebola virus disease. And these include very young or very old age, as well as higher viremia levels and elevated levels of AST, BUN, creatinine, certain cytokines such as interleukin 6, 8, 10, and macrophage inflammatory protein 1 beta, ferritin, and D-dimer. So also decreased levels of albumin and calcium and an antibody response are considered risk factors for mortality. We also need to take into account the patients that have significant hemorrhagic disease are likely at higher risk for death. Pathology autopsies have demonstrated focal necrosis without inflammation in the liver, spleen, testes, ovaries, and in the pancreas, and signs of hemorrhagic diathesis in all organs. There's also some glial nodular encephalitis that has been noted throughout the brain of fatal cases. So significant renal damage and signs of tubular insufficiency also occurs. This is also from autopsies. And lymphatic tissue demonstrates plasma cellular and monocytoidal transformation with basophilic bodies that have been noticed near necrotic cells or as inclusion bodies in parenchymal cells. So this is, again, from pathology, but we can see that all organs may be involved, and there's also the evidence of encephalitis in patients that succumb to Marburg virus disease. So how about sequelae or prolonged convalescence? So survivors of Marburg virus disease have experienced prolonged convalescence with numerous sequelae, including myalgia, malaise or fatigue, hyperhidrosis, skin desquamation, amnesia, testicular atrophy, decreased libido, and hair loss. And again, we need to highlight the live virus have been recovered from samples of semen and aqueous humor from up to 3 months after illness. So Marburg disease has also been found to persist in testes of non-human primates that have survived Marburg disease. And we know that there was at least one survivor that transmitted infection to his wife through sexual intercourse more than 2 months after recovery of illness. So how do we diagnose a patient with Marburg virus disease? First of all, we need to have a high index of suspicion, right? So the diagnosis can be made using multiple modalities, including culture, RT-PCR, serology, and immunohistochemistry, depending on the time course of the infection. Typical diagnostic samples include blood and other body fluids and tissue obtained at autopsy. Reagents for Marburg testing may not be as widely available as for Ebola, and clinicians in the United States should first contact their state health department regarding a patient under investigation with suspected Marburg prior to submitting any specimens. If the state health department prefers that specimens go directly to the CDC for testing, then the specimens will be shipped to the Division of High Consequence Pathogens and Pathology within the viral special pathogens branch. And this contact information can be easily found at the CDC website. Other potential sites for such shipment include the Biosafety Level 4 laboratories or the Diagnostic Systems Division of the U.S. Army Medical Research Institute of Infectious Diseases. And their number is 1-800-USA-RIID. So, because of the early stages of the disease, clinical diagnosis of Marburg virus disease can be difficult to distinguish from any other febrile illness because of similarities in the clinical symptoms. So the epidemiology and the history, considering residence, occupation, travel, food storage, animal exposure, sick contacts, etc., within the last 3 weeks is key to actually be able to think. So clinicians should consider other viral hemorrhagic fevers such as Ebola virus disease or Lassa fever, as well as other infectious diseases, including malaria, typhoid fever, leptospirosis, rickettsial infections, and plague. So the initial case in Ghana presented with fever, general malaise, and this is 2022, bleeding from the nose and mouth, and subconjunctival bleeding. The individual tested positive for Marburg virus by RT-PCR. At the Noguchi Memorial Institute for Medicine Research, and the results were confirmed by the Institut Pasteur in Dakar in Senegal. At this point, there are no Marburg vaccines that are approved in the US or worldwide. So when we're talking about pre-exposure prophylaxis, we know that at this point, there are no approved vaccines. There is no cross-protection between the Ebola and Marburg virus vaccines, although several constructs tested in cynomolgus macaques have demonstrated protection against both Marburg and Ravan viruses. So there are currently 3 candidates for Marburg vaccines that are in phase 1 clinical trials, and 1 that is scheduled for a phase 2 or 3 clinical trial. When we talk about post-exposure prophylaxis, using a vesicular stomatitis virus vector vaccine that incorporates Marburg glycoprotein, reduced death when given within 20 to 30 minutes or 24 hours, or as later 48 hours to rhesus macaques. So at this point, we don't have any pre or post-exposure prophylaxis that is approved. So this is why infection prevention becomes key. We can see here that out of the vaccine candidates, we have the one that is going to move quickly to phase 2 and 3. So this is actually good news. How about clinical management? So there are multiple pharmaceuticals that are active against Marburg that are in development. And this include immunotherapeutics, phosphorodiamidate, morpholio oligomers or PMOs, lipid encapsulated small interferon RNAs, small molecule inhibitors, interferons, and antiviral nucleoside analogs. So at this point, the most important thing that we can do, consider that there's no approved medical countermeasure, is supportive therapy. There are some antivirals that are off-label that we're going to discuss quickly, and also some monoclonal antibodies. So although there is non-human primate data for favipiravir and remdesivir that appear favorable, there are no data to indicate whether either would be beneficial in humans. Remdesivir was used in the PALM trial in 2018-2019 for the Ebola outbreak in DRC, and did not appear to be as beneficial as the monoclonal antibodies preparations. It is unknown whether the same would apply to Marburg disease, but given that background, it's reasonable to consider monoclonal antibodies as potential first choices for treatment, but if available, of course. So galidesivir demonstrates some prophylactic efficacy against Marburg up to 24 hours. These are phase 1 results that are still pending. So at this point, given the less robust response to Ebola virus disease for remdesivir, galidesivir might be a potential second choice below a monoclonal antibody preparation, such as the MR191N. That is the one that has most data behind. We can see here the antiviral options. We can see galidesivir, and again, this is a phase 1, but appears to have good response. We have favipiravir, and we know that favipiravir is licensed in Japan for influenza. And we have remdesivir, and we know that remdesivir has been tested for Ebola with good results, but not as good as the monoclonal antibodies, but it's one of the approved medications that we have and was approved for COVID. So it's available in most developed countries. And when we talk about the monoclonal antibodies, we have the MR191N. That is the one that can be used as an emergency and was used in the US for a lab exposure. So how about infection prevention and control? So Marburg patients might be optimally managed in specialized biocontainment units. So in the absence of a biocontainment unit, infection prevention and control guidelines for Marburg are similar to those for other viral hemorrhagic fevers, primarily consisting of barrier nursing techniques, including the use of personal protective equipment such as gowns, gloves, masks, and face shields or goggles to prevent contact with blood or body fluids. Strict adherence to the correct use of PPE with attention to hand hygiene and prevention of self-contamination, especially during DOFIN, is required. Patients should be placed in a single room with dedicated bathroom or commode. We know that the U.S. Environmental Protection Agency registered hospital disinfectant with efficacy against enveloped viruses, and this is the one that should be used to disinfect environmental surfaces. Single-use medical equipment should be used when possible, and reusable equipment must be cleaned and disinfected according to the Spalding classification scheme that is available at the CDC 2008. Both the CDC and the World Health Organization have developed a manual of infection control for viral hemorrhagic fevers in African healthcare settings that is available in both the CDC and WHO website. The CDC has also developed guidelines for managing Ebola patients in resource settings. And these are also indicated for Marburg and include focus on the use of PPE, waste management, cleaning and disinfection, and other aspects of the management. And additional resources can also be available at www.nitec.org. As we can see on the website here, this is the one that is highlighted. We can have some PPE recommendations and instructions on how to use from the NITEC website. To reduce the likelihood of occupational exposure, the use of needles and sharps should be minimized whenever possible. Facilities should develop plans to manage employees who may have an exposure to blood or body fluids. Also, aerosol generating procedures should be undertaken with extreme caution, preferably in an urban infection isolation room, with providers wearing appropriate PPE, including respiratory protection. In the United States, waste generated in the care of patients under investigation or patients with confirmed Ebola virus or other viral hemorrhagic fevers is subject to procedures set forth by local, state, and federal regulations. And again, there's extensive guidance that can be found at the CDC websites. So it's important to highlight that Marburg virus disease is a zoonosis, but human-to-human transmission occurs. It's a viral hemorrhagic virus disease, and it's from the family of filoviruses, similar to Ebola. At this point, we have no approved vaccines of medical countermeasures, and in the United States, it requires the activation of a biocontainment unit whenever possible. We need to keep in mind that epidemiology and history of the patient, at least within the last 3 weeks before the viral illness, is key to have a high index of suspicion and be able to make a diagnosis. I recommend that you can read this Marburg virus disease, a summary for clinician. It's a great review that was conducted by the Medical Countermeasures Work Group within the Special Pathogens Research Network. Also, regarding Marburg, you can listen to the website is highlighted in yellow, but you can see a quick updates on what happened in the outbreak in Ghana during July 2022. And we would like you to reach out to any of these resources to get a little more information, both on NITEC, CDC, WHO, as well as this is the citation for this review on Marburg disease. On behalf of the Mountain Plains Regional Disaster Health Response System and the Denver Health HIT team, thank you for listening to this talk. And please email your questions, type in Marburg question in the subject line to maria.frank@dhha.org. Thank you very much and have a good rest of your day.